Assalamu alaikum wa rahmatullahi wa barakatuh. Sorry for the delay, technical issue. Anyway, I'm delighted today to talk to you about anterior segment trauma, tips and tricks. We all are facing it during our daily practice, and mostly today we are going to discuss it. It is not a lecture, it's just a discussion to know our practice and to improve our routine practice and routine management of cases of trauma, because this is a life-threatening, vision-threatening cases, and by just following up a certain routine and step-by-step approach, we can reach good results and save the vision for most of our patients. It can start from very trivial trauma to major traumas. We can face it during our daily routine in clinics or those who are in general hospitals and ERs. Ocular trauma, how often we see it in our daily practice? We can talk together. As I told you, it's a discussion, it is not a lecture here. We can see it daily or day after day, or how often we can see it? Daily. At least foreign bodies, yeah. At least foreign bodies, we are seeing it daily. What is the routine workflow for management? How you are approaching these cases? We will come to it later on. But first of all, we have to take a good history. History is the main milestone for our management of trauma. Visual acuity for medical legal. Once you have the patient, you have to take visual acuity, record it, document it. Never touch the patient without checking the visual acuity. Visual acuity is it can save you and it can save the patient. Assessment of the injury. Is it superficial, deep, penetrating, whatever the cause, is chemical or thermal? What is the situation? What is the history? What is the how this injury happened to the patient? We have to know this all. Is it ocular or extraocular? Is it superficial or deep, blunt or penetrating, chemical, acidic or alkaline? If there is any tissue loss or bone fractures. And the most crucial is the imaging. What image you are going to ask for it? Either plain plain X-ray, CT, MRI. If there is no magnetic foreign bodies, you can do an MRI. If there is fractures or tissue loss, ultrasound. If there is penetration, so you cannot touch the eye. If there is closed globe, so you can do ultrasound, OCT. So whatever means you are or tools you have to use it and utilize these tools. So which and when? This is the imaging. So in our management, what is our setting? Is it in ER or clinic? This will differ. According to the situation and according to the tools you have, it will differ. If there is a life-threatening condition, stabilize first. Don't touch the eye. Stabilize the patient first. Tell the ER doctors, just stabilize. After you stabilize, I can deal with this patient. But don't go and there is a life-threatening condition and you are doing your job. No, leave it for them until they stabilize it, so you can do your job. The step-by-step approach and slit lamp examination, especially if you have portable slit lamp, it's crucial. If you have portable slit lamp, or if is this what about it? Talking is about ER. But if you are in clinic, all tools you have. So documentation. What whatever you have, just document it. We are in a country that anyone can assume you make mistake. So just document whatever you see. Visual acuity, intraocular pressure, fluorescein staining. Whatever you have, if there is a closed loop, just do fluorescein staining. It will not harm you and it will not take time, but it will give you a clear view of your path. Whether to do patching or bandage contact lens or shield only, you have to know when to do this and when to do this and when not to do it. If there is an open globe, don't touch, don't press. If there is just an abrasion, there is a debate either to use a contact lens or not to use a contact lens, but we will talk about it later. Is the globe rupture or is a closed globe? Either to do a primary repair or secondary repair. This has to be decided during seeing the patients. Either to use antibiotic and which antibiotic and which strength of antibiotic to use and when to start using it. So as you can see, this is just a corneal abrasion transferred to corneal ulcer. And after this you have an hypopium. So this is all comes in sequence. We don't need to reach to this situation. This is a case, you can face it. As you can see, one eye, pinpoint pupil, and the other eye is just no pupil at all. What is your expectation of this? He comes, I am not seeing anything. What is your expectation of what happened to this patient? Anyone has a clue or idea? This is after I give him the medication. So what was the situation? Anyone has any clue? Myotics? No. I am freely practicing my life and suddenly I cannot see. No trauma. There is no trauma, no history of anything. So simply, and you can see it, is exposure to pesticides or insecticides. It comes like a myotic pupil, but in this case, the pupil was completely closed. Once you put mydriatrics, it dilates the last picture here. So simply, if you take a history from the patient said that they put pesticides or insecticides in my home, and this was from 1 or 2 days. Simply, he comes to you crying, I cannot see. And you can face it. And I saw it many times. In this case, you can see I stain the pupil, I stain the cornea. What you can see here? Just a regular surface, okay? And there is no figure or pattern for this staining. It's just an irregular cornea. And patients coming painful, angry, red eye. Look at the second picture. What you can see here? Okay, I will come. Even I have to come here. Look with the staining, look at this area. This edge. You can see it? You see the next picture? You can see the edge clear now. Neglected contact lens for 1 year. And comes angry red eye, crying, and at the end the lens is just as the inner canthus. You can see it. You can see the edge of it here. Here is the edge of the lens. And you can miss it. Simply you can miss it. You can see it now with this here. You can see, as you can see, this is the edge of it. So taking history, did you bought a contact lens? Oh yeah, it's from a long time. I remember that they bought a contact lens, but I don't remember when. And it's neglected for 1 year. So history is crucial to manage this case. Here, just micro rupture of sphincters, and this we can face it. Blunt trauma, you can get this small micro ruptures of the sphincter. It can come up to widely dilated pupil. Here, primary repair of a glue with anterior capsular rupture. You can see the glue. It's a very nice primary repair, but you can see a cataract with anterior capsular rupture. Another case, primary repair for a case, and it comes with this end, scarred cicatricial ectropy. So he did his job, but at the end it was not a good job. The patient comes with tearing, and at the end this is a cicatricial ectropion just from the scar. So whatever you have and you know your capabilities, you have to stick to it. Referral is a crucial here. If something I cannot do it, it's better to refer, because at the end they will assume. So it's better to do whatever we are perfect in doing it. This is not my video, by the way, but I brought it because I saw these cases a lot, and I am using this algae brush from since time I came here to Saudi Arabia from 2001, something like this. This is the algae brush. Okay, this is a diamond pearl just to clean the rust ring. A lot of us doesn't know it, but it is mandatory to have it in your clinic because it will make your life easier with the rust ring. I will show you the video. Here, one of my cases. This is a picture is the rust ring, and after cleaning, you can see it is very nice cleaned bed. And here is the video. This is the rust ring. Okay. First, try to remove it with the needle as well, all doing it just to clean the rust ring. It comes very easily. The older way is just to give ointment and antibiotics for 2 or 3 days until this rust ring comes up and you can clean it. But sometimes it cannot come up and the epithelium healed over it and you can find the rust ring forever. But with this pair, as you can see, it is like your battery hold. You can just by your finger control the movement of it. You can stop it and it doesn't have a button. You can see the bird. It is just like a drill. It will clean this rust ring in just seconds. So I urge everyone to have this in clinic. It's something like 300 riyals or something like this. You can get it through Amazon, through AliExpress. Some of the companies they are being bid by higher prices, but you can get it through these websites. In these cases, as you can see, a patient came to me with this plain X-ray, normal, nothing, but you can see this is an inlet, there is a rupture anterior capsule. I expect there is an intraocular foreign body, but with X-ray you cannot see anything. Here you can see the rupture is very evident, clear, anterior capsule, and you have cataract. This is in just few days. So, I didn't see anything. And for me, I cannot, in these cases, either to know where is the foreign body or don't just struggle. If you cannot see the foreign body, there is a foreign body. It penetrates the eye. Where it goes? Either posterior segment or orbital. Ultrasound done, you cannot see anything. So, it's better to refer it to retina or do an MRI. If I am an anterior segment surgeon, I cannot find the foreign body, so I will remove the cataract. And at the end, where did the foreign body went? Okay. So we have some cases. This is a nice case, and that was referred from one of our colleagues here. This case, it went around for a few days. Angry red eye, foreign body, clean, but at the end it is not improving. The eye is angry. Here is the picture before. As you can see, there is just this white part here, limbal only. And it's not that big deal. You have a limbal like a reaction, it is not, it is an inflammatory part. But you cannot see any foreign body. Okay, this is the slit lamp examination, just like an amalgamated part at the limbal area, but nothing is seen. So I did a gonioscopy, and this is the surgery for this patient. I found an angle foreign body. Let's make an opening and fill the anterior chamber with viscoelastic. Do a gonio lens, surgical gonio lens. We are putting viscoelastic over the cornea, and this is the gonio lens. Here you can see the foreign body inside. You can see it. It's the black part, the blackish area inside this amalgamated area. I go by forceps and just grasp it and take it out. If this cannot get by, if you go by IA, you cannot get it. It's more very deep in the angle. It was impacted in the angle. So with gonio lens, this is the foreign body. It's very small, but make the life for this patient. Angry eye, red eye, inflammatory, he is not improving with any medication, and searching all around. But at the end, once you remove this and remove the amalgamated reaction, okay, clean the blood. Second day, you will find the eye completely white because you removed the main problem. Here is the picture. Second day. The second day goes off. You can see the eye becomes white and the area is clear. Second case, this is a deep intraocular foreign body. This I did it from a long time, but I found the video. It is not that nice. This is as you can see, it is penetrating, not completely penetrating the cornea. I try to get it by forceps. You cannot get it. It is impacted. So you have to make a small, like a radial incision to get it out. I try to get it. I cannot get it. I try to catch it by many forceps. I cannot catch it. And you cannot push it down. You cannot push it inside. You have to take it out because you cannot know if there is an infection around it or not. So as you can see, once you dilate, it's very minimal, and I can just even I try to. This was like a hole, but it is not with fluorescein. It was not stained. There's no suicidal negative. So just I give the subconj, put a contact lens, and leave it to see what is the course of this patient. Because you cannot do anything more. You have to take the foreign body, and then even I didn't do rustering removal because I don't like to enlarge it more. Leave it, heal it by itself. It takes time, but it will improve with time. But you remove the problem. This patient came with trauma. There's an inlet, anterior chamber. There was an anterolenticular foreign body. You can see it by the investigation. As you can see here, this is the sham flow camera. Look here. This is the foreign body. It was intralenticular. And if you suspect an intralenticular foreign body, it is better to this is very evident. You can see it inside the lens. Okay, so you have to adjust a routine phaco, but with these cases, you have to be careful not to push it through the posterior capsule. You have to go around it, even by just an IA. And once you catch it, take it out. And if you take it out, it's better to take it, not to aspirate it to the machine. Because this is a medical legal, you have to let the patient see it. So as you can see, this is the capsulorhexis. As you can see, there is sidrosis, shows long standing. So with IA, just aspirating, and you can see the foreign body now. So I will just go around it, I'm not pushing it, I'm just trying to aspirate it. Once grab it, I take it out. It's here, that's it. This is the foreign body. So this is sometimes, subhanAllah, this is, when you see some patient like this, it's a forceful penetrating foreign body, and at the end it stays inside the lens. You will see another case. This patient was completely denying that he has any trauma at all. I tried to, even you are going to workshops, you are passing by someone drilling, nothing. He's saying that I was not even near it to it. And when I examined him, look the slit lamp examination. Here is the slit lamp examination. You can see there is an inlet, and you can see the foreign body inside. You have a foreign body. No, I cannot remember anything. Even when you see the rupture of the anterior capsule here in the sham flow camera, there is a rupture here. This is the rupture that penetrate the anterior capsule. Okay. So this is a video for it. Once you dilate the pupil, as you can see, you will find the sidrosis all around. See how much sidrosis? So it's the same. You have to do our rhexis. No need for hydrodelineation or hydrodissection at the beginning. You can just go by IA or phaco until you aspirate the foreign body, and then you can deal whatever you want to do, you can do. As it was a white cataract, this patient was coming hand motion. And alhamdulillah, after removal of the foreign body, second day he was 20/20. He was not believing that he reached this, alhamdulillah. But this is just because of foreign body that he cannot even remember it. Here I saw the foreign body now. So I just try to catch it slowly. No, I will engulf it in the phaco, so I will take it by forceps. Better, as I told you, you have in this denying patient, you have to let him see what he was having in his eye. And just completing the surgery as usual and implanting the intraocular lens. This baby, it was like 8 months or something like this. He told me that his brother was holding a needle and the needle goes to his eyes. And he came with this picture. Stereosynekia, penetrating inlet in the cornea, and you can see the cataract. Yes.
After removal of the body, we remove the lens.
Yeah, we are doing like a phaco. We are doing a phaco emulsification and implant the lens, implant a new lens.
Complete.
So, yeah, complete surgery. Yeah, I cannot. I'm just for the time because I have a limited time, so I cannot. I'm just even making the video just 1 minute or two, something like this. I don't want to take long time, but I need to just take a scope around what we are going to face and how to deal with it. So this is a picture. You can see the inlet, corneal inlet. Okay. This is a phaco blade. I just give in the posterior synechiae. I do synechotomy and just or synecholysis and just doing the anterior part of the capsulorhexis. This is a soft cataract. You can do by IA, even just IA, regular IA. But in children, we have to do a posterior capsulorhexis. But at the end, this was just playing together and a needle, just penetrate his eyes. The debate in these cases is either to implant or not to implant. And if you implant, you have to work with zero with us. Or if you implant, you have to tell them that mostly you need to exchange later on. But you cannot leave a monocular eye with no lens.
We can take eyeglasses after the surgery.
Hmm?
Or eyeglasses after the surgery, and then we can pull up your front.
Even the eyeglasses for one eye, this will not. It is a problem with monocular. It is not a binocular case.
I mean, even after the contact lens, you still wear the glasses so it's not.
Yeah.
But
So it's better to implant and tell them we need to. Later on, we will exchange this lens, but they have to understand the situation. There's another baby also. Same trauma, penetrating trauma. It comes to the eye, and so it's 2 years old. The problem here is that you have a huge defect in the anterior capsule. This, I will show you some of these strange cases. I try to. You can see this opening. This area is totally open. You can see this here is the opening. So I get a capsulorhexis around this opening. Okay, try to complete it, and then IA. You have to clean the cortex as much as you can, then doing the posterior capsulorhexis, and at the end implanting the lens. Here, this was a strange case. This is something like 30 years old. He came, he said that, this nebula, the rubber of this, it can just hit his eyes, only. And he came with this picture. You see hyphema, traumatic mydriasis, rupture of the iris, and this was not the problem. The problem with this case that you are expecting that you will have a high intraocular pressure. This case was a hypotenuse, something like 5, and stays for like 1 or 1.5 months with this pressure, and you cannot find any clue for what happened to him. It's very trauma. It is not a cleft. It is not cyclodialysis. Everything is okay. Just this trauma only. And if you are having this hemorrhage, it's supposed to increase the pressure. But mostly this patient have ciliary shutdown from a trifle trauma. It is not that big trauma that can cause all this problem. And by the way, he was having also a vitreous hemorrhage. So there was a zonulosis, the bag was not stable. I cannot even do it with capsulorhexis, regular capsulorhexis, so I have to penetrate by needle doing the capsulorhexis. You can see this corrugation, this was in the posterior capsule. And this corrugation part was in the posterior capsule. So doing our routine phaco, but we have to go to CTR. I try to get, this is a soft cataract, but the problem is that the back is not stable. Flip and trying to get it. You can see the corrugated posterior capsule. There is an opacification in the posterior capsule. So here I do capsulorhexis, posterior capsulorhexis with this unstable. No, unstable back. Don't do a posterior capsulorhexis now. Just leave it, and you can do later on YAG laser capsulorhexis.
what's the age of the patient?
30 years old. So implantation of the lens, and then he was having a problem with this dilated pupil. So you have to do pupilloplasty to close this defect. So with the in iris only, this you have the 4 through 1 pass or sepsar sliding node. You can just take one node, it will improve. You can see I just by manual, by forceps, I grasp the iris and pass the needle and complete it. And this was his picture after 2 months. You still have the posterior capsule opacification, iris slightly better. You can just took only one suture, but it is better that he can tolerate light now. This is a very nice case also, that you can have a case like this, white cataract. And I do routine phaco. This was a traumatic cataract, by the way. All cases are traumatic. So I just go, it is routine, I cannot see any problem. I do my capsulorhexis. Okay. You have here, I am not doing it because I did a few complete before, so I just, it was a fibrosed, slightly fibrosed, so I just do my routine hydrodissection, hydrodelineation. I am not suspecting any problem at all. And then go to doing the phaco part. And once I clean some part, look here. Look at this end. Okay. You see the edge? I have a huge posterior capsular defect. But subhanAllah, even with this case, the anterior vitreous space was intact. So I just complete my phaco. I am not seeing anything dropping down. Even you can see this pacified part on the vitreous. I just clean it slightly, and then it's like a posterior, subhanAllah. It's from Allah, posterior capsulorhexis. Just I implant it in the back, and the case was very nice, and I completed it safely without any vitreous or any. Okay, but in trauma cases, you have to expect the worst. Don't be self-confident that everything is okay. This is the problem with plantar trauma. 8-ball hyphen. Okay. In these cases, if you lift for a long time, you can have corneal staining and the clot will be fibrosed. And look, when when I going to aspirate it, it is a fibrosed part. It is like a clot. So just aspirating, trying to aspirate, even I go with forceps to catch it, but you have to take it out. And the problem in these cases, you have to tell them, expect that we have a rebleeding. Don't be sure that I will remove it and it will be okay. No, we can have rebleeding later.
What was the tension of this time before you interviewed, and how many days did you wait?
No, I didn't wait. It comes to me. It was a referred case. It was something like one week or so.
The tension again?
No, it was very high.
Sorry?
It was high. The blood was something like 30 or something like this.
Yes, you still by alternative.
Trauma 1 week. Yeah. So what are our key point to remember? We have to make sure that there is no associated injuries. Life-threatening, stabilize first. Orbital, you have to know if there is any just a closed loop or open loop. Okay? We have to make sure that the patient is stable, check the globe if it is open or closed, protect the eye from pressure, as we told you, this either shield or don't press if it's an open globe. Imaging to know what is the situation, to know what is the problem, the extent of injury, and the long-term follow-up after treating for cataract and glaucoma. And our thanks for our sponsor today, Miracle and ST, for their really, they have nice lenses. They have a portfolio of monofocal, EDOF, trifocal, everything. It's very nice lenses, and this is, you can see, all the lenses, they have the whole portfolio. And I think Dr. Ahmed will talk to you about it. So thank you very much, and I hope I just cover part of the trauma. It is a big part, but I tried as much as I can. Thank you very much.